of the ACHD program at the University of California in San Diego. And he's going to talk about a topic that I think is a hot topic in congenital heart disease these days, is how the transcatheter edge-to-edge repair technology or techniques can help our congenital heart disease patients. So, Laith, thank you very much for accepting the invitation today, and the floor is yours.
Thank you so much, Rafa, and I appreciate the invitation, and I look forward to meeting everyone and having this conversation. All right. Let's see. These are my disclosures. I will be discussing off-label use of the MitraClip system, and I have no relevant financial disclosures. So this is the overview of my talk. We'll start by review of the physiology of AV valve regurgitation. It's going to be a quick overview followed by epidemiology and some of the outcome studies that were done on adults with congenital heart disease and AV valve regurgitation. And we'll talk briefly about the care organization that is required to achieve transcatheter edge-to-edge repair for these patients. And we'll spend the majority of the time reviewing several cases that are recent from our program. In a biventricular circulation, the lowest point or pressure point, typically it's the EDP, end diastolic pressure of the ventricle. And in the case of the systemic ventricle or the LVEDP, and the majority of patients, that's immediately preceded by the wedge or the left atrial pressure. So it's only makes sense to think that a patient with AV valve regurgitation will encounter a substantial problem in their forward flow and cardiac output once AV valve regurgitation ensues, because that invariably will increase, at least in the immediate term, the left atrial pressure of the wedge. And eventually, as the ventricle is unable to accommodate the volume loading, the EDP, the end diastolic pressure, will increase, and the patient will become more symptomatic as the back pressure to the lungs with a poor cardiac output. This is fundamental knowledge in any biventricular circulation, and I think obviously the extreme would be a single ventricle or Fontan circulation, where you don't have a subpulmonic compensatory pump. An elevation EDP or the wedge will almost certainly guarantee worsening of the cardiac output and symptomatology in these patients. But the vast majority of our patients exist along a spectrum between these two extremes, and invariably they will be affected by any AV valve regurgitation in terms of functional capacity and quality of life, and for some, survival. And indeed, Tariq Al-Said has shown in this eloquent study that in patients with Fontan circulation, single ventricle Fontan circulation, the strongest predictor of mortality among these patients is a combination variable of moderate to severe ventricular dysfunction or moderate to severe atrioventricular valve regurgitation. And the rationale for lumping or including these two variables in one is that sometimes it's very difficult to disentangle, whereas ventricular dysfunction begets severe AV valve regurgitation and vice versa. And therefore, analysis in such fashion makes complete sense. And it was by and large the strongest predictor of mortality in this cohort. And if you take the same concept and apply it to other patients with congenital heart disease and biventricular circulation, but also at high risk of AV valve regurgitation, ventricular dysfunction, the congenitally corrected transposition patients, you will find that these two variables as well pop up as very strong predictors of the combined outcome of death or mechanical support or transplant, which are pretty hard endpoints. In this study, they did not specifically address the correlation between TR or systemic atrioventricular valve regurgitation and RV dysfunction. But one can deduce that the two probably play hand in hand in these patients. And in general, the organization of care, when we're addressing any atrioventricular valve regurgitation in our ACHD patients, follows along the same lines of what many of us do in an organized adult congenital heart centers. And that includes a multidisciplinary conversation and evaluation by multiple providers before a decision is made, whether that patient undergoes repair or replacement of the AV valve, and what mode of replacement or repair should be attempted. And similarly here, we have similar conversations. And I would say the pre-catheterization planning is foundationally important in these patients, and buy-in from the surgeons and support when you're attempting these procedures is of utmost importance. And lastly, shared care decision with the patients, making sure they understand what are the success rates and what to expect after this type of procedure, because some patients may not be able to undergo surgical repair after deployment of these clipped devices. So it's important to have these kind of conversations with the patients. The currently available transcatheter edge-to-edge repair systems on the market are, at least here in the US, there are two. The one on the left is the mitral clip system, which was made by Abbott. On the right is the Pascal system, which is made by Edwards. And for the remainder of this talk, we use here the mitral clip system on the left hand here. But they're very similar in concept, and also the sheath and the delivery system. So with that knowledge, let's just kind of jump to cases. And I would like to start by a more bread and butter clip patient that may not necessarily be under the care of an adult congenital heart center, but also that would be a good entry point for many people contemplating starting this procedure at their centers. So this was a 21-year-old patient with severe intellectual delay due to chromosome 9 duplication. And he is known to have some mitral valve prolapse and regurgitation, at least since late childhood. At baseline, he's only able to ambulate and walk around the house, but he does require a wheelchair for longer distances. And this has been his baseline. However, more recently, over the past few months, his parents have noted significant decline in his functional capacity, where he has been avoiding ambulation around the house, and they see that he's been sweating and feels fatigued most of the time whenever he attempts physical activity. So he prefers to sit in his wheelchair all day. And this is his transthoracic echocardiogram on the left upper corner here. Let me see if we have, no, we don't have pointers here. Apical 4, a modified apical 4 chamber view showing severe mitral regurgitation, and another view here of the same lesion showing fairly significant prolapse of that posterior leaflet, causing central severe regurgitation, as evidenced by an effective regurgitant orifice of 0.66 and mitral regurgitation volume of 97 milliliters, which is quite significant. His LVEF calculated at 45%. So he's already had seen some decline in his systolic ventricular function. So this patient was discussed in the multidisciplinary conference, and due to his severe intellectual delay and relatively favorable anatomy for transcatheter edge-to-edge repair, the family opted to proceed with this attempted procedure. So this is intra-op in the cath lab TEE with multi-slice view. So I'll point your attention to the 3D. That's how I usually like to start these cases. Look at the 3D of the valve to know the lay of the land before you start honing in on the individual leaflets and sections of the leaflets. So this is a fairly not dysplastic valve the anterior leaflet is intact. You see the posterior leaflet has two large scallops. This is not a true commissure or a clift. And you see that there's prolapse of both of these components, more so the lateral portion, which has almost complete prolapse and almost flail section to it. So now as I'm planning these procedures, we sit down and we look at this valve and we talk about our initial clip strategy and subsequent strategy. Meaning that this valve, you really want to stabilize it before you address this main prolapse segment. And due to this large, not cliff, but scallops here that are fairly separate from each other, most likely this patient will require two clips to stabilize this valve. So we start off initially by identifying the appropriate height and the location for transseptal cross of the device. And it has to have a certain height to it. Approximately 4.5 to 5 centimeters is the sweet spot. And that allows the maneuverability of the system and straddling of the valve before delivery of the clip. And on the left hand X-ray or fluoroscopy view, here you see this is the clip delivery system sheath, and it's traversing the inner atrial septum. And now the clip is has been unsheathed here in the middle of the atrium. And once that happens, then you can start straddling or turning down to the valve and opening the arms of the clip here on the TEE images. And you see the clip now is under the valve. And when it's under the valve, you would like to obtain what's called a grasping view, which is the area of the largest separation between the two leaflets of interest that you're trying to clip here, which in this scenario, it's the anterior and the medial component of the posterior leaflet. And you can see here the posterior leaflet is already inside the clip arms. And the clip arms have two different components, the main arm, and there's something called a gripper. And that gives you guidance that the leaflet has fallen inside the clip arms and probably ready to be closed. And as you do that, you maneuver to the other side and grasp the anterior leaflet. And eventually, what will happen is that both leaflets will fall into the clip arms, and then you're able to close the clip arms as seen here. And once the clip arms are closed, you want to make sure there's adequate insertion and there is no significant tension on the leaflets to avoid tearing. And we do multiple maneuvers, pull and tug, and also evaluation of the transmitral gradient, which is important because you don't want to cause mitral stenosis. And this is how this first clip is shown after it had captured the anterior leaflet and the medial component of the posterior leaflet. And the clip is still attached to the CDS, or the clip delivery system, the sheath here, just before release. So once the clip is released, or once the clip is deployed but not released, you really want to study the mitral regurgitation behavior. And in this scenario, we notice that the MR jet has been split now around the clip. And generally, you don't want to see that. You really want to be on one side of the regurgitation to allow yourself to deploy a second clip device. So what we did in this particular case, we released the valve. We didn't deploy the clip right here, and we attempted recapture of the leaflet closer to the lateral component. And this is the second capture right here, which appeared to be much more adequate. And now you see the MR jet is only on one side of the clip, this is the prolapsing segment of the lateral component, the posterior leaflet right here. And that's where the remainder of the MR jet is. And that's where you want to target your second clip. Because once you release the clip from the spear here, the sheath, you can't recapture it. And this is after release of the clip. you see the MR jet is exclusively lateral to that first clip that was deployed, and now we're setting up for the second clip deployment. And right here, similar fashion, you go in with a second clip and you straddle the valve, you go under it, and you capture the anterior and the posterior component here. And this is after deployment of the second clip. And what you see here is a triple orifice mitral valve here, here, and here. And this is the transventricular view that both clips attached to the atrioventricular valve, the mitral valve. And this is on fluoroscopy after complete release of these two clips. And as you can see here, there is mild residual mitral regurgitation from two separate jets, but it's a substantially reduced MR fraction compared to pre-op for this patient. So that patient did extremely well. Post-op had some lung issues, recovery after the intubation, but eventually he's in rehab now and doing fantastic. And the transmitral gradient was very minimal, it was 2 millimeters of mercury. So now that we've discussed a patient that has more standard anatomy, let's kind of review some of our more complex cases with congenital heart disease. This is a 52-year-old patient with L-lobe transposition or congenitally corrected transposition. Never required any surgical operation in the past. His first presentation was at the age of 42, her first presentation when she developed complete heart block and required a transvenous dual chamber pacemaker replacement. This pacemaker is not MRI compatible. She did very well, and in her history, she had 3 children without any complications. At baseline, she's quite functional, able to do a lot of activities, enjoys hiking, and has no symptoms. However, over the past year, she's developed progressive dyspnea on exertion to a point where she was admitted with acutely decompensated heart failure and was initiated on diuretic therapy. And currently, even after therapy, she remains in New York Heart Association functional class 2, and her quality of life has been significantly affected. And this is her transesophageal echo. I'm not going to bother you with the transthoracic. So this is a relatively modified 4-chamber view, mid-esophageal. What you see here is the large tricuspid valve or atrioventricular valve, which is quite tethered. And there is, I would grade this as torrential tricuspid regurgitation due to significant malcoaptation of the leaflets centrally, as seen here on the 3D view. So this is functional tricuspid regurgitation. The valve itself, it's not extremely dysplastic, or it's not an epsinoid valve, which renders it as more favorable for transcatheter edge-to-edge repair. And to support her symptoms, quite significant symptoms, you see here pulse wave Doppler across the pulmonary veins, and you see significant systolic flow reversal in ventricular systole consistent with her torrential tricuspid regurgitation. But pre-op, before we did this, we did obtain a CAT scan, computed tomography. Again, this patient has a pacemaker that is incompatible with MRI. And what you see here is that this systemic right ventricle is significantly enlarged with an end-diastolic volume index of 181 milliliter per meter square, with an ejection fraction that is relatively preserved at 54%. I would caution you, though, that we really don't know what this ejection fraction means in a patient with torrential tricuspid regurgitation, meaning we don't know the underlying true systolic function of this ventricle. Once you address the tricuspid regurgitation, eliminate and increase the afterload for this ventricle. But nevertheless, we felt she had favorable anatomy and physiology to proceed with transcatheter edge-to-edge repair. I would like to emphasize that transseptal puncture is probably one of the most critical steps of this procedure. The reason why, it really sets you up for success. And you have to study these hearts by multimodality imaging, typically with CT and TEE in combination before you take the patient to the cath lab. The reason why is once you know exactly where you're going to puncture, you want your the sheath, you want it to traverse the valve really around a commissure so that you're more perpendicular to the valve when you're attacking it with the clip. And that allows much easier maneuverability of the clip delivery system up and below the valve as you try to capture the leaflets. If you don't have a favorable transeptal puncture, that could actually lengthen your procedure by an order of magnitude. So it's really an important step to do before continuing with the procedure. So here we obtain transeptal access, and right here we're straddling the valve, and we were able to capture the septal and the anterior leaflets. Generally speaking, with tricuspid valves, you almost always want to capture the septal because that's the least mobile portion of the valve, and that allows anchoring of the valve. And it's important to note that with these tricuspid valves, you are changing the anatomy quite substantially when you're deploying a clip. So what you saw before deployment may be completely different in terms of mechanism of residual regurgitation after deployment of the first clip. And you have to have a strategy and think ahead of time whether you want to have a single clip or multiple clip case. So right here, after deployment, this patient had significant residual tricuspid regurgitation. So we opted to deploy a second clip right here that's slightly lateral to the first one, and it's still attached here, and it has adequate insertion, and the leaflets are relatively slack here, but not too much slack. And again, this is post-deployment. So we've taken this tricuspid regurgitation systemic right ventricle patient from torrential tricuspid regurgitation to now, after 2 clips, to a moderate tricuspid regurgitation, which frankly, you should declare victory in this particular patient because you really need to look at other physiologic parameters, the left atrial pressure, and importantly, the pre and post clip. After each clip, we look at the pulmonary veins, because even in the landmark usual heart failure studies or non-congenital studies, this was one of the strongest predictors of improvements in quality of life for these patients is elimination of systolic flow reversal in the pulmonary veins. And in this particular patient, after the second clip, you see almost normalization of pulmonary venous blood flow without any significant gradient across this tricuspid valve. The mean gradient is almost only 2 millimeters of mercury, which is quite good. So we opted to stop at this point. And this is her transthoracic echo the following day with contrast imaging because of poor acoustic windows. Gives us better endocardial definition, particularly for these systemic RVs that are heavily trabeculated. And we calculated the fractional area change at 36%, which is technically normal. And even the RV free wall strain was also in the normal range for this patient. So symptoms substantially improved, and currently we're waiting for repeat testing at the 6-month mark. I would like to bring the study that many people quote. It's a fantastic study that really ushered the evidence for AV valve replacement or intervention for patients with congenitally corrected transposition. The study comes from the Mayo Clinic, and many of us are familiar with it, and it drives a lot of our decisions. They've looked at all patients who underwent tricuspid valve replacement. It's important to understand this cohort and what it doesn't say. So it didn't really address the issue of all patients with tricuspid regurgitation. Their inclusion criteria included all patients who underwent a tricuspid valve replacement at the center, which is a large referral center for tricuspid valve replacement in this anatomy. And they stratified the patients by tricuspid valve replacement, pre-surgical RVEF. And those who had an RVEF of 40% or more were more likely to survive after 10 years of follow-up. But pretty much everybody survived the actual surgery itself. So it's important to know that sometimes the fear of RV dysfunction or RV shock following AV valve repair, it is a significant concern, but also it shouldn't be the sole decision when we're contemplating percutaneous edge-to-edge repair, particularly with these patients, since we're not putting them in cardiopulmonary bypass. It's an iterative and flexible procedure where if you're after deployment, if you see the parameters of the RV are getting much worse, or the blood pressure is dropping, patient's not doing well, sometimes we keep holding on to the clip for half an hour just to see how the patient is handling it. And even in very sick patients, we've never really seen worsening shock. But the data is still in process and emerging in this particular population. So the third case is also a systemic right ventricle. In this scenario, it's a patient with D-loop transposition of the great arteries who underwent palliation by a mustard atrial switch operation earlier in life. And he was lost to care up until this current point in time where he became more symptomatic and in fact was recently admitted with acutely decompensated heart failure and discharged on diuretics and guideline recommended therapy. And currently he's in functional class 2, and he's on a moderate dose of oral Lasix. And he tells us he would really like to regain functional capacity. And we've had the patient meet both our transplant team, surgical team, and transcatheter teams together, and in multidisciplinary fashion again. The team decided to offer this patient transcatheter edge-to-edge repair for severe TR. But before that, his MRI showed an RV ejection fraction of 28% and an end-diastolic volume index that was quite significantly large at 183 milliliters per meter square. So this patient already has heart failure, quite significant heart failure in face of severe tricuspid regurgitation. So his true RVEF is probably much lower than this. It's also important to know that a lot of these patients with mustards, oftentimes transthoracic echo, sometimes it's just inadequate to adequately quantify TR. Sometimes it looks less than what it is. And in this patient, indeed, with MRI with 4D flow, we were able to measure a regurgitant fraction of 48% of TR, which is quite significant. It's right here in this green backward arrow to the left atrium here, and this is the right ventricle. And indeed, when you look at the transthoracic echo, sometimes one might call this tricuspid regurg as less than severe, but indeed it is severe TR. So here we start the case. It took a lot of pre-procedure planning because of the baffles that you really need to know where you're going to cross the baffle. In this patient, we opted for a modified axis approach where the most favorable transbaffle puncture position could be easily achieved or easily achieved by going from the IJ or the internal jugular vein from the neck of the patient rather than from the transfemoral. This does require significant changes in the setup of the room, but we were able to achieve that. And here we achieved transbaffle puncture that is quite high because the atria in these patients is not enlarged and you don't have a lot of room of maneuverability. But once you obtain the transbaffle puncture right here, you advance your wire, and then the sheath, which is large right here, is traversing the baffle, and now it's floating into the left atrium with a pulmonary venous red atrium above the valve, and now you can introduce the clip before straddling this valve. And right here, we do a lot of imaging, both mid-esophageal 3D and also transgastric for tricuspid valves in order to confirm what's called perpendicularity of the clip arms with the valve. You really want the clip arms to be perpendicular to the plane of the valve leaflets you're trying to capture. This avoids partial capture of the leaflet and subsequent detachment. So it's important before you close the arms that you have good perpendicularity. And once we've confirmed that, With a lot of steering sheath maneuverability, we're able to capture both leaflets here in the center of this valve. And sometimes we start in the center and just see what happens. You are changing how this valve is behaving substantially when you do this. And sometimes you get lucky and you can eliminate TR with one clip. And indeed, in this case, this patient had no significant TR after one clip in the center of the valve. And that's where we decided to stop. And this is his next day transthoracic echo, showing mild residual tricuspid regurgitation and a clip here in adequate positions, well seated with adequate tissue bridge. His fractional area change was 18%, which is not significantly different than his pre-intervention, and hemodynamically he did very well after this procedure. We are yet to see the long-term effects of this intervention, because traditionally, at least in our center, before doing these edge-to-edge repairs, we've sent these patients for consideration for transplant, but we do have transplant backup for this patient as well. So this is another case, a little bit more complex. This is a 38-year-old patient with cyanotic congenital heart disease, previously unrepaired, showed up in her mid-30s, immigrated from Mexico, cyanotic. She has crisscross atrioventricular valves, SLV segmentation, and she had valvular and subvalvular pulmonary stenosis and hypoplastic tricuspid valve, and she was quite cyanotic. At age 35, she underwent percutaneous Glenn anastomosis, which was reported first in human. That was done here at UCSD and Rady Children's. And then this patient did very well. Her saturations remained in the mid to high 80s after the Glenn anastomosis. But 3 years later, she developed quite significant progressive decline in her functional capacity. And she was found to have severe mitral regurgitation. And this is the TEE for this patient. As you can see, this is the tricuspid, the mitral valve, and the left ventricle right here. And on FOSS, because of the crisscross relationship, you see the hypoplastic tricuspid valve right here facing you. And what you see here is you see prolapse of the anterior leaflet of this mitral valve and quite significant mitral regurgitation. Again, pre-planning is paramount in these patients. And for this particular patient, she also had a secundum ASD in the inner atrial septum. You might think that that could be advantageous as we're trying to do a transbaffle or transseptal puncture, but indeed it's not, because we rely on a transseptal puncture as an anchor for the sheath and the clip delivery system. So you really need to traverse a wall to rest your sheath on it as you're doing the maneuvers of the clip. So in this patient, we had to do 3D printing of her heart and bedside trial and error, and until we identified the optimal position of transseptal puncture, which is right here in the right lower panel. And we proceeded with the cath, and indeed you see the ASD right here, and we crossed the septum adjacent to it, and we were able to straddle this valve, and it took a lot of maneuverability. Ryan Reeves did a fantastic job with this case. He's my structural adult interventional colleague, and I was able to bridge this valve between the anterior and the posterior leaflet. And this is her residual mitral regurgitation, which is mild to moderate in severity. Given the length of the procedure and the patient's status, we opted to stop this case because the left atrial pressure dropped significantly after this first clip. But it's also important to note that in other types of patients, if you encounter two atrioventricular valves, you can be fairly aggressive and not worry too much about mitral AV valve stenosis if you have two egresses of blood into the ventricle, the single ventricle. This is a sicker patient. This 15-year-old patient was born with heterotaxy, unbalanced right dominant complete atrioventricular canal and total veins. He underwent repair with an extracardiac Fontan using a 16 millimeter conduit. in year 3 of life. And then he developed progressive failing Fontan circulation over the past few years, predominantly due to torrential atrioventricular valve regurgitation. And indeed, he developed cardiogenic shock, and he was started on inotropes and transferred from out of state via air flight to San Diego for consideration of advanced therapies. And when he arrived, he was really sick, unable to speak in full sentences, sitting upright, extremely uncomfortable, shocky. So we debated whether to put him on ECMO immediately and list him for transplant, or bridge him with some sort of intervention for the AV valve before transplant. So we opted to proceed with TEER, a transcatheter edge repair, as a bridge to transplant. And this is, to give you an idea, his transthoracic echo. You see quite enlarged single ventricle. It's an atrioventricular canal patient with substantial, I would call it massive, wide open atrioventricular valve regurgitation, regurgitating all the way back to the pulmonary veins. And his opening left atrial pressure was 30 with waves to 60 millimeters mercury. And on 3D, which is partially obscured by the baffle, you see here there is a very large coaptation gap that is central, traversing the entire anterior and posterior components of this AV canal valve. So this patient really was in trouble. And we were able to cross the Fontan conduit via the transfemoral access and straddle this valve. Really, our strategy here is not elimination of atrioventricular valve regurgitation, rather than reduction of regurg, and also reduction in the left atrial pressure. And after deployment of one clip in the center of this valve, regurgitation would reduce to severe range. So it was in the massive or torrential range previously, and it was now severe. So it's important not to just look at echo and be that the sole determinant of your procedure. You have to look at the patient. The patient had severely reduced ejection fraction, is on multiple inotropes, sick, and left atrial pressure was able to be reduced now to the 15 range with V waves in the 20s. So almost halving of his left atrial pressure. So because of that, we felt that this was an adequate result, and we stopped the procedure. And eventually he underwent a successful transplantation. The last case here is a 23-year-old patient who was born with a complex single ventricle, double outlet right ventricle, complete atrioventricular canal that is right dominant, and also had valvular pulmonary stenosis, mitral atresia. And he underwent several operations for repair, and also had stent in the Fontan tunnel, and eventually underwent a second stent inside that stent. So for us, when we're thinking about atrioventricular valve regurgitation and access to that single atrium, it is next to impossible if you have stents like this to go across. So, for this particular patient, he had moderate RV dysfunction, he had severe TR, functional class 3, really to a point where he was using a wheelchair to shop, and he was not a candidate. We reviewed him for transplantation. Unfortunately, he has very difficult social challenges that rendered his candidacy obsolete. So he was declined by the transplant team. And the strategy now, as a palliation, because in lieu of transplantation, we had surgical support and backup in case the transcatheter edge repair doesn't work. The surgeons were willing to take this patient to replace this AV valve, but in that scenario, it would be a very high risk type of intervention. So this is his transesophageal echo showing severe central functional AV valve regurgitation in the center of this valve with a large central malcoaptation gap. We opted through a kind of unusual out-of-the-box approach for this patient. So we went through his right-sided glen into the proximal PA to the roof of the atrium. And that's the sheath being advanced, dilator being advanced over the wire across the atrium. So that's a pulmonary atrial access to the single atrium. And that allowed us to actually land right on top of this valve. And you can see here on the right side picture, you see the Fontan stents here that are overlapping. And you can't insert this size sheath across these stent struts. So really had to look for alternative access. And we required also intracardiac echo to assist in access because it's such a high and close to the esophagus that we couldn't really visualize it very well on TEE. But here after the patient, you see tenting here of the atrial roof and the sheath being introduced into the single atrium, followed by the clip, and now it's across the valve with open arms. And you already see this anterior leaflet has fallen inside the clip arm, and it's moving the gripper, which indicates adequate insertion, at least for the anterior leaflet. And we keep adjusting the position of the clip and doing different maneuvers. And indeed, the first clip was successfully deployed and released. Here, we're releasing that clip. That spear here is very important to kind of watch it. So after release, we track it with the TEE until it's sheathed and the patient is safe. And then we can focus our attention on assessing the atrioventricular valve following this clip introduction. And you can see here that's a double orifice mitral valve, good atrioventricular valve with good tissue bridge. And there was significant residual atrioventricular valve regurgitation. So we proceeded with a second clip immediately adjacent to that first clip to stabilize this valve. It was extremely challenging because there wasn't enough leaflet to grasp, but eventually after multiple hours, we were able to grasp it. And this is the second clip deployed here and released next to the first clip. And this is the final result with mild residual atrioventricular valve regurgitation and no significant increase in the transvalvular gradient and no stenosis. However, I bring this case because this was early on in our experience as we're learning this technology. And we noticed on the transthoracic echo the following morning, the patient had a single leaflet detachment, meaning that one of the clip arms detached from a single leaflet, but it remained attached to the other leaflet. So embolization is generally very rare of these devices, but the patient did have increase in the atrioventricular valve regurgitation, which is now in the moderate range. But we opted to just keep watching him. And his functional class improved. And it's not uncommon for these patients for the ventricle to remodel. Once you reduce the regurgitation from a torrential magnitude to moderate range, you anticipate some remodeling of that ventricle. So the functional component of the regurgitation may improve with time. And indeed, that's what happened with this patient. And his functional class improved, and we opted not to proceed. This is the data that we're preparing for publication. We're combining our data with another center for a larger cohort, but we've performed 19 cases here at UC San Diego. 5 of these patients with Fontan. This shows the AV valve regurgitation severity. We were able to reduce it to 1+ or 2+ in the vast majority of patients. And those that were reduced 4+, because there's no like 5+ designation for pre, those are the patients who had massive AV valve regurgitation. We reduced it to severe magnitude. And many of these patients will significantly improve their function. Remember, these patients are discharged the following day, and there's no, obviously, surgical scar. So in these patients, we've encountering significant improvement in functional class. So in summary, this is meant as a introduction to this technology to the ACHD community and awareness that it is available for our patients. We started early on with patients who were not candidate for surgical intervention, but we've partnered with our surgeons and in shared decision-making with our patients and offer these patients transcatheter edge-to-edge repair. But also we have a backup option for many of these patients, oftentimes currently, whereas if we are unable to reduce the regurgitation significantly, then we will not release the clip. We will abort the procedure, and then the patient can go for an operation as well. It's important to note that not every valve is amenable for this procedure. You have to study the valve anatomy with TEE before, and oftentimes you require multimodality imaging with CT and MRI for access points. And you really have to think and spend the vast majority of your time discussing the access site and the optimal site for transatrial transbaffle puncture, because that could mean success or failure of the procedure. And straddling of the valve and the angle of approach are critical steps inside the procedure just before you deploy the valve. And the nuance of the anatomy could matter significantly, and that could pose significant challenges. So in the case of access, a transbaffle or transatrial access, that's considered technically a difficulty in the case. But we also have some opportunities for patients with congenital heart disease. If you have two atrioventricular valves, then you can be a little bit more aggressive and not worry too much about stenosis for these patients. And it's really important. I view this as an entry point or on a continuum of a continually accelerating adult structural interventional field. The field is being completely transformed with these new devices, whether it's replacement, a lot of atrioventricular valves or mitral valve, transcatheter mitral valve replacements are coming on the market, and also the repair techniques. So I feel it is critical that we take this technology and translate it to adults with congenital heart disease by de-risking this procedure and having active engagement of ACHD providers in the planning phase to entice our adult structural colleagues to come to the table with us and offer these technologies to our patients. But it remains an evolving technology requiring more evidence in our patients. And lastly, I'd like to thank my team, our team here at UCSD, and particularly Ryan Reeves here on my right hand. He is our structural adult interventional cardiologist, has been a phenomenal partner throughout this process. Thank you.
So thank you very much, Laith, for a fantastic presentation. So if you have any questions, just please write them in the chat, and I will ask them. But we have already one on the chat, so I was about to ask you the first question, but we have the first question here from Dr. Garon in Alberta. So wonderful talk, thank you. Has there been much experience in adult patients with AVSD in patients with biventricular heart who have had surgical repair in childhood and after they have a severe or significant left AV valve regurgitation?
That's a fantastic question, Anita and Rafa. It is. I have to say that we get a lot of these patients reviewed in our meeting, and we've opted not to offer patients with large residual clefts. A lot of these patients with AV septal defects who've had repair in childhood, the mechanism of residual left atrioventricular valve regurgitation is often a combination of not a true residual cleft. It's just the area of prior cleft repair doesn't grow as the rest of the valve grows, so it remains cleft-like appearing. But the valve often is extremely degenerated in that area and rigid, and also it's unsupported. So if you clip one side of the cleft, the other side is unsupported, and it makes it very difficult. I'm aware of 1 or 2 case reports of people doing clips in these valves, but for now we have not done that.
So another question from Dr. Bellman, Grushan Bellman in Glasgow, in Scotland. So what are some typical, congratulations from the talk and said that is excellent talk, and said, what are some typical procedure times at your current level of experience with some of these complex cases?
Yeah, thank you, Grushan. So the typical time, boy, so we don't book other cases, basically, when we have no idea. I mean, if it's a patient, the access or the transeptal or the transbaffle puncture, if it goes smoothly, it is really unpredictable how long the rest of the procedure will take. In a Fontan, we know that case will take sometimes up to 5 hours. But in a mustard or an L-loop TGA patient, we've had patients who it took 6 hours because of the valve maneuverability. It was very difficult to capture the leaflets. And in some, it took 2 hours. So it's highly variable. We have reduced significantly the length of the procedure by upfronting a lot of the pre-procedure planning. And also, oftentimes you discuss these patients months in advance. So we do like a powwow before the procedure. We look at their CT, MRI, TEE before we even do the intra-op TEE, so that we can all agree on the morphology of the valve and the access points and the optimal position for the transseptal puncture. So we've reduced it by 40% by adopting these techniques, but these are very lengthy procedures, but they're still shorter than surgery.
For sure, faster recovery. And Dr. Osley from Toronto is saying that most of our patients have these plastic valves. Of course, that is one of the limitations of the technique. So what is the morphology of the valve that would say, look, this valve is just a no-go?
Yeah, it's a great question, Erwin. So honestly, like a classic Epstein or Epstein appearing valve, we don't do clip. We get offered sometimes patients and refer these patients, but we offer them surgical intervention. But that's the extreme. It's kind of interesting. Early on in the experience of the usual adults without congenital heart disease, the patient and the morphology of the valves have become only more complex, and they're offering these procedures to tricuspid valves that look quite degenerated. And this procedure relatively works, at least to improve their symptoms in the tricuspid position. For our patients, our approach is changing as we gain more experience with this technology and be more comfortable, to the point where we can have a conversation with the patient and the surgeon and say, yeah, the valve may look unfavorable, but we can give it a try. And we have to all agree on what residual regurgitation it's acceptable. If we all agree that this patient should have no residual regurgitation, so anything short of that, we abort the procedure. And then the patient can go and have their surgery done. That happened twice. But typically in patients where you really need to eliminate all AV valve regurgitation because otherwise the ventricle function is good and they're good candidates for surgical repair. So that's basically our approach.
Another question from also Erwin said that you, of course, for these cases, you have to have a backup. Things can go wrong always. And the question is, how many patients of what you presented have failed? So you presented the good cases. How many of them you have failed, or how many of them have gone to surgery urgently?
Yeah. So again, failed meaning you do the procedure and you declare that you've done it and then it doesn't work. But if you have it's the strategy that you enter. I mean, the strategy going into like one of the cases where they had massive regurgitation, the strategy is to reduce it. So clearly you have not eliminated the regurgitation. But to answer your question, there were a couple of patients where as a preemptive strategy, what we did was go into it knowing that we need to eliminate the regurgitation, and then we aborted because we couldn't think that a clip can eliminate the regurgitation, and the patient underwent surgery. It's important that you do this up front and you have an open conversation with the patient and the surgeon, because sometimes if you deploy the clip and then you end up with less than adequate regurgitation, residual regurgitation, then that patient most likely will not be able to undergo repair. The surgeon has to go in and replace the valve because the clip is there and it's already tied to the valve. Obviously, unless you take the patient immediately to the OR, but there's almost never a scenario where a walking patient, when you do this procedure, that you put them in shock or diastrates outside of a usual, axis bleeding and things like that, which we haven't encountered. So generally speaking, again, we always thought of the systemic RV, particularly, or the single ventricle with severe AV valve regurgitation. We worry about the post repair shock. as you increase the afterload for these patients. But you always have to remember pretty much all this literature comes from surgical series, where you can't really disentangle the contribution to the shock from elimination of afterload after you replace the valve, or the bypass itself and the cardiac arrest that the patient has to go through in order to fix the valve during the operation. That's why a lot of these patients' post-operative course is very tenuous. We have not seen that here.
So I don't want to finish with two couple technical questions. As someone that is in the lab in the imaging side doing these cases in non-congenital patients. So do you have who does the imaging for your patients? Is somebody with experience in congenital heart disease, TE, or do you have any member of the
Oh, great question.
Of the TriClip or the clip team that structure that's the structure in general?
So the way I got sucked into this was serendipitous, because we had shortage of structural TEE general kind of cardiologists, echocardiologists, and they asked me to start doing them. So I started doing them on regular patients, and that's how I gained enough experience in able to identify patients with congenital heart disease and take this technology to my patients. But it's the same adult structural interventional cardiologist who does them in regular patients, who is not trained in congenital heart disease, but joins us in all the congenital heart interventions, is the one doing this procedure. So this procedure is kind of the opposite of traditional congenital heart intervention, where the vast majority of the onus is on the imager. And once you kind of decouple the congenital aspect of the imaging and the procedure, pretty much it's basically a clip. You put it in an atrium under a valve, and it's for them it's the usual steps once you help them get to where they need to be.
And the second question is more technical on the interventional part. Do you use TriClip in the systemic tricuspid valve, or do you use a mitral clip in the
these two clips are the same. I mean, they call them TriClip, which is made by Edwards, because the delivery system is more maneuverable. But the mitral clip system had another delivery system that also maneuverable. So they're the same. They call them TriClip.
I know the clip is the same, but the system is different, right? So
yeah, but the second generation.
I always think that the TriClip in the master is a much favorable maneuverable device to using a buckle that the original TriClip delivery system, which is more stiff and you need more space in order to deliver the clip. So that was.
We use the mitral clip system with the most recent steerable system, and I think it just works well.
So Erwin has the last questions, and is that if you have a patient with moderate to severe AV valve regurgitation after the first procedure, and you leave the patient with moderate to severe, would you go back in 6 months to do a second clip?
That's a great question. We haven't done that because really you can deploy a second clip and see what happens. Don't release it. And see what happens. We do a lot of measures for the systemic ventricle to make sure we're not running into issues. We do DPDT. We look at EF. We wait for a lot of time. We ask our anesthesiologist to kind of reduce the support to see if the blood pressure remains stable. And oftentimes, if you just put a second one, and then there's no increase in the stenosis, and you're reducing the regurgitation, the patient's hemodynamically okay. Honestly, it's a lot easier sometimes to just release it, do a second one in the same setting, because the transseptal axis and the setup and everything takes usually much longer than the procedure itself.
So just as a comment for that, Erwin, as I'm experiencing a non-congenital wall, the clip also has the valve becomes stiffer, and doing a second clip 6 months later probably is not going to work. So if you do a second clip, you do it in the first procedure, or at least in the non-congenital patients, and if not afterwards, it's probably not a great idea.
Exactly, and also if you're thinking I might deploy a second one, you usually want to start by putting a clip that is more anterior, because if you put a posterior position clip, then you're shadowing your anterior second clip position because you're looking from TEE, and you just can't do this procedure without TEE. So it's important to kind of start far from the TEE probe and then work your way closer to the TEE probe if you want to put other clips.
Correct. So on that note, I think we have to finish. So Laith, really, thank you very much for the excellent talk. So also, thank you very much for leading this. I think it's a fantastic approach to some of these patients that have nothing better to offer to them. I always tell I try to convince the team here to do these things. And I tell them that when you do a normal, a general cardiology patients, they always aim for perfection in not having a valve regurgitation. If you leave me a single ventricle with moderate, I'm very happy, from severe to moderate. So they don't have to do perfect. They don't have to aim for perfection. Just to as you show in some of your cases, reducing only half of the regurgitant volume significantly reduce the pressure of the atrium, and that is going to be significant change in the hemodynamics of patients with, for example, single ventricle. So really, thank you very much. I was really looking forward to hear this talk, and you done a fantastic job. And for all of you that have attended, thank you for coming, and see you in a couple of weeks. And good morning, good afternoon, or good evening, wherever you are in the world. Thank you, Laith. See you around.
Thank you, Rafa. Thank you, everyone.